Good afternoon, Pnawn da pawb. Welcome to the Welsh NHS Confederation Wellbeing for Wales webinar, How Digital Supports the Transformation of Health and Care in Wales. I'm going to give a quick overview of what we do at the Welsh NHS Confederation, talk you through some housekeeping around how the event is going to be run today, introduce the event, and then introduce our speakers, and we'll open up. The Welsh NHS Confederation is the national membership body representing all the organisations that make up the NHS in Wales. The 7 local health boards, 3 NHS trusts, Health Education and Improvement Wales, and Digital Health and Care Wales, who we'll be hearing from today. We're part of the NHS Confederation, which operates in England, Wales, Northern Ireland. Our mission is to be the voice of NHS leadership in Wales, to empower, enable and support the whole health system in Wales to deliver high quality care, reduce health inequalities and become more efficient. Some housekeeping from us. The session is being recorded and will be made available as soon as we're able to after the event today. Please can you keep your microphones on mute and cameras to remain turned off for the duration of the event. If they do come on, we are able to switch them off for you, but please try your best to avoid any embarrassment by switching them on. We host a series of webinars under the hashtag Wellbeing for Wales brand. The next event following today is on the 7th of November, which looks at some work we've been doing with health boards and the Arts Council for Wales and the value of arts in health. More importantly than that, the next large event that the Welsh NHS Confederation are putting on is the annual conference, which will be taking place on the 1st of November, which we'll be promoting widely. Unfortunately, this is a postponed event due to the passing of Her Majesty the Queen, so this event is rescheduled, so please check your diaries to see if you are able to make it, because registrations are still open. On to today's event. The pandemic saw rapid transformation across health and care, especially through digital innovations. These were an important part of the pandemic response and enabled patients to continue accessing care at a time when physical appointments weren't able to go ahead. In this Wellbeing for Wales webinar, we'll be reflecting on key lessons learned during the pandemic and looking at some of the national digital programmes in progress, such as the NHS Wales app, digital medicines, and the National Data Repository. If you don't know what all of those things are, I'm sure you will by the end of today's presentations. Speakers will discuss the biggest opportunities and challenges for digital health and care and what these mean for NHS in Wales. I'll introduce our 2 speakers today. Evan Evans, who's the Executive Director of Strategy within Digital Health and Care Wales and was formerly in Welsh Government. And Stuart Morris, who's Director of Digital at Cwmtaf Morgannwg Health Board, but also chairs the Directors of Digital Peer Group, which brings together Directors of Digital from all of the NHS organisations in Wales. I'm going to hand over to Stuart and Evan to open up the discussion, setting out some reflections. Questions are going to be put in the sidebar, and I'll answer those as the discussions develop. Without any further ado, I'll hand over to our panelists today.
So first of all, thank you, Darren, and thank you for the opportunity to join you this afternoon. So good afternoon, everybody. Pnawn da. As Darren alluded to, I'm in a really honoured position to chair the Directors of Digital Peer Group across Wales, as well as my role within Cwmtaf Morgannwg. And I guess actually, if I just reflect firstly on the peer group itself, which really has been born out of a response during the COVID pandemic, that the pandemic gave us a real opportunity to come together in a way that perhaps digital teams across Wales hadn't before. We'd been probably much more focused on our local issues, and clearly, while we want to address the digital needs for our organisations and our communities, there was definitely a sense of coming together, far more greater teamwork than perhaps we've ever had. And as a result, we developed this very much professional peer group response. And I guess some of those some of the other things that were just unlocked during that was the ability to act and act quickly. There was a lot of interference perhaps in the system before, and I mean that interference in a nice way, which probably prevented us from moving at the kind of pace and scale that we were able to do during the pandemic. So working together, cross-organizational boundaries, working together with national services, we really saw that quite quickly, actually, if we reflect now that and we were trying to do it in a staged way around moving people into virtual meetings, virtual conferences, etc. That would have taken far longer, but actually it was almost, and I really do mean that, within within the matter of nights, weeks for some teams perhaps, we got organizations online working together in a way that they never had before. So a huge shift actually, and what then becomes apparent is that digital then is not just something to support colleagues in their day-to-day work, but actually a core fundamental part of enabling services to be delivered across Wales. So it was really tough. I know it was really tough for everybody, teams working ridiculously long hours to support and keep people safe. But actually that ability to respond in the way that we did, is something to be commended. And obviously now that sets an expectation for the future. But I don't know if Ivan wanted to add to that in terms of early reflections.
Yeah, Joch, Stuart, and thank you, Darren, to you and the Confed for the opportunity to look back on things. I think I'm just going to try to draw out a few reflections, I suppose, or lessons learned. I'm sure most people on the call will be familiar with the broad sweep of how digital was part of the pandemic response. To such an extent, it's hard to imagine how we would have done what we did as a system in response to the pandemic response without the digital elements. It would have been almost impossible without the video consultation platforms that we had for clinicians and patients, but also the Teams arrangements that ran the entirety of the pandemic response across the NHS, and the contact tracing system and the vaccine system, and a whole host of other things. It was absolutely crucially important. And the two things I guess I'd reflect on, not so much lessons learned, but one that actually Wales did a really good job relative to other parts of the UK in terms of the performance of some of those things, like contact tracing, the rates at which we were able to follow up within 24 and 48 hours, vaccine, the pace of our delivery, our utilization of what were at the time scarce dosage. We were better in terms of outcomes, and we were significantly lower in terms of cost compared to the benchmark across the UK. And I think that reflects the common digital systems that we use that were very sort of standardized and efficient. Also, the partnership approach that we have across the NHS and local authorities, particularly. And that is a little bit easier to do in a relatively smaller system like Wales and a more compact system than a larger, confusing system like England. The couple of things I'd like to draw out, I guess, are we did, at the time I was in Welsh Government, the audit committee of the Health and Group asked for a deep dive onto the pandemic response. What were our lessons learned on the digital thing? And there were a few things that we pulled out there. One was we kept being told, asked, that the only reason we were able to do this was because we completely changed our approach to risk in the public sector. And a good thing too, because the public sector is risk averse. And my response to that was we didn't. We used the same governance and the same processes that we had before. Procurement was compliant and decision-making was compliant. We were using gold, silver, bronze, emergency response type structures, but we used all the existing structures that we had. And I think the key thing that changed was the risk horizon, the time frame over which we were trying to make decisions about what to do and what not to do. And my view is it's really hard to predict what's going to happen over a 3-year period or a 4 or 5 year period. And you quickly find a stack up of uncertainty and all the things that could go wrong. And then you've got to manage against them, because it only takes one person to say, well, what about, and then you've got to mitigate. If you're working on a 3-week or a 2-month timetable, there's a lot less uncertainty. It's pretty clear what you've got to do and by when. And also you find out really quickly if you're doing it wrong. The feedback loop is drastically accelerated, and you find out almost immediately if you're doing the wrong thing, and you get a chance to adjust. And I think that was a key thing. The pace, the cadence really helps to drive things through. And the second thing was a really drastic simplification of our funding and decision-making mechanisms. As Stuart said, the digital directors peer group has been kind of tempered in the fire, but it grew out of what initially was a 3 times a week gathering. So we'd meet for an hour on Monday, Wednesday, and Friday, collectively as all the digital leads for all the organisations plus DHCW plus Welsh Government, and make decisions there and then in the room, knowing that the funding was not something we had to be overly concerned with at the time, because Welsh Government was funding everything centrally through the main pandemic reserve. And that took away so much of the complexity that we have embedded, across our systems. And then from a technical perspective, we also drove hard to simplicity. We had one contact tracing service, web hosted, provided out across the whole of Wales. We were training everybody at the same time in 30 different organizations on common, hour to 2 hour recorded sort of webinars, taking immediate feedback from frontline users, playing that back in. We trained 2,500 people in a fortnight, I think, or something like that. That's not the way that we usually work. And my final quick thing is just to say that, to caveat that, because everybody thinks, well, didn't you do well in pandemic? Why can't you just do that all the time, right? And the services, the digital services we delivered for the pandemic were greenfield services. And we did not have a national contact tracing system. We didn't have a national vaccine booking and delivery system. We didn't have national test reporting, test results reporting in the way that it was delivered through mass testing centers and this kind of activity. And it's much easier to build something fresh when you've got nothing to let go of. One of our big challenges in the NHS is people hold on really tightly to the way that they work, the way they're familiar with working, the way that they're trained to work, the way that they prefer to work. And we didn't have a lot of that because nearly everything was brand new. And that enabled us to go more quickly. And we'll talk a little bit more about future large scale transformation programs. But in almost all cases, they require changes to existing practice. And that is much, much harder than a crisis, pandemic, emergency response type of situation where it's all new and everyone is learning quickly. And nobody's really got time to dig into their own way of working because it's new for all of us and it's hitting us all at the same time. So yeah, just some sort of 3 headline brief reflections, I guess.
No, thanks both for the interest and reflections. And just recently, I've been looking back over the sort of COVID period with a view to the sort of learning and things that are coming along in terms of the public inquiry. And it's easy to forget the actual enormous changes that happen, particularly in digital on what some people outside the NHS might call pretty basic things like the sort of broadband capacity for NHS sites across Wales. And I'm far from an expert in these subject matters, but the size of the pipes, as it was described to me in many meetings, is huge credit to everyone there. Some of the things that did happen really quickly, you've touched upon. But one of the other things we said we'd try to cover today is some of the national digital programs. And I think some things that were initiated through the COVID period have now become national programs, and in some cases, normal ways of doing business. So just interested to hear views from Stuart and Ivan around the national programs which were part of the title for this event.
Yeah. So thank you, Darren. And actually, just before we get there, that your last couple of points actually around some of the building blocks and foundations we can't lose in this. And actually, all of our organisations across Wales are really struggling on a daily basis to make sure we maintain keeping services live, keeping services up. The funding models that Ivan alluded to, all of those things have to come into play before we get onto some of the perhaps more innovative, more transformatory stuff. As organizations, not losing sight of the day job, not losing sight of the core foundations. Again, if you think about the pandemic, and I know we're going to move on, but if you think about the pandemic, we mobilized hundreds, thousands of staff right across Wales overnight with laptops or devices for the first time. And as Ivan said, that's a lot easier than perhaps taking them through a change process where people have used these devices before and actually now just going to ask them to use them in a different way. It was all new. So there's a number of things we need to think about. One is making sure our infrastructure across Wales is sufficient, but also not losing sight of our workforce capabilities as well, and having a digital ready workforce. So some of the work that I'm doing with our peers at digital directors and working with our workforce colleagues and HIW is looking at our digital competencies and needing to make sure these are all in place, because actually putting new digital transformation programs in without ensuring we've got some of these basic principles in place first is really fundamental to the success of the transformation journey for NHS Wales. And then when we think about some of the programs, and I'm sure Ivan's going to come in a moment on some of these in some detail as well, but actually we've got our routine, we've got our day-to-day stuff, but actually moving our patients to be far more empowered, looking at things like the digital services for patients and the public, the NHS Wales app is a great opportunity to really change the way in which and the face of which healthcare is supported and provided. So we're all, as organisations across Wales, looking at what our patient-centred focused platforms look like, how do they interact, how do we change models of care to really work in a much more digital way. And it's a fantastic opportunity for us, and that's underpinned by some really core programs of work that are being facilitated by Digital Health and Care Wales. There's other clinical opportunities and medical opportunities that I'm sure Ivan may allude to in a moment. But I guess for me is, before we go there, we do really, as a system, need to understand that we've got to get some of these basic principles right as well, and not lose sight of that when we're trying to move into a new world. I don't know how you feel about that, Ivan, but
yeah, no, I think they're really strong points, and you've got to have solid foundations. And I think to a degree we were very fortunate. I don't want to say we were fortunate in the timing of the pandemic, right? Because I wish it had never happened. But by luck, we had done a few things during the 6 and 12 months before that turned out to be very useful. And in particular, coming off the back of the audit reports from the Public Accounts Committee and Audit Wales, Welsh Government had just committed a substantially increased amount of investment into digital, and lots of that went into infrastructure, desktop estate, and network infrastructure and servers across the whole of Wales during the 3 to 6 months before the pandemic hit. So that was enormously important in enabling us to very quickly step up the use of digital on things like Teams and Office 365, and also a number of key programs. So the Office 365 program itself, the National Data Resource Program, and some others had been given the green light from Welsh Government during the second half of 2019, and that meant that when the pandemic hit, the teams were already in place, and it was possible then to speed up the delivery, because as we all know, recruiting and building a program team from scratch is not something that you can do instantly overnight. But the teams were there, and in some cases they were repurposed. So a lot of the architectural and development design resource that had just been recruited into the National Data Resource Program was turned onto the Welsh Pandemic Record and into test booking and integration and various other things. And the Office 365 program, which had a plan over 3 years to do all sorts of stuff and to do Teams right at the end, because nobody knew what Teams was in February 2020, turned that on its head, did Teams first, and had rolled out Teams to 100,000 people across the NHS in Wales by the end of April. I mean, an unbelievable result. And then went on to finish its whole 3-year implementation program by the end of 2020, in 9 or 10 months. I mean, the effort that people put in and their willingness to work together was amazing. We could not have done that if the teams weren't already in place. So I think we were lucky, and that infrastructure as foundation has got to be there. Do you want me to say something about some of the programs that we've got at the minute?
Yes, please. I was reflecting back as you were talking about the enormity of that task, rolling out 365, and I was sort of reflecting. You mentioned it, the sort of lean ways of decision making that we saw, and I'm going to be slightly sort of cheeky, really, and point a finger that I think back to how we worked in the Welsh NHS Confederation. You'd get together monthly for your big set piece meeting. You'd have all the chairs together. You'd have vice chairs together. You'd have chief execs. You'd have directors, and there was some sort of reticence really to move to digital from them. And I look now, and it's a struggle to get all those people in the same room. And one of the other pieces I reflected on it, and I find it as somebody who isn't particularly technically adept, is when you're in an office together and you're not quite getting how a system works, you can wander over and chat to somebody else about it. But when we're all, many miles apart now, that's a challenge. And, great credit to you all in the support that you've given to people on that. But we've got a couple of questions coming in, which I'll start to correct, but I'll hand over to you to say a bit about the programs which are going on.
Yeah, so I think we flagged a couple of programs in the spiel, I suppose, for this conversation. So to cover some of those, the National Data Resource is a really, really important foundational program, which tries to consolidate all of the data that we have together. I'm going to just draw out one thing which is maybe slightly different in concept to similar work which they're doing in England, and then something which draws through on the pandemic learning, I suppose, that we have. So the first, England are working on what they're calling a federated data layer. They're putting a large procurement package out, which is currently suspended or paused. And that is, and I may be doing it a slight disservice, but in my mind, I'm simplifying a little bit. That is a sort of an extract upwards and aggregate type of data federated layer, right? If you want to be able to deploy things with a lot of interoperability and standards compliance, you've got to find a way to characterize your data in a consistent manner, but you've got a universe of different systems already in use across healthcare. So the English approach is to try to pull data out of existing systems up to a standardized data layer, federated layer, and then present that up to systems that work on top of it. I think that our approach to the national data resource is slightly more foundational in the sense that our ambition is that the principle or the concept that we're trying to adopt is that we would write data down to the layer as a foundational layer. It doesn't go quite as far as Estonia and the principles it applies about data only ever existing in one location, but we are trying to move to a system where all of our active systems are writing information down to a sort of a common repository, a common data resource, which is standards compliant. And then I'm doing that in-house, doing that ourselves with partners. Obviously, we're using Google Cloud for part of the hosting and various other things, but we're doing that in-house rather than outsourcing it to a third party. And then the other thing I think that is interesting in the national data resource is the experience we had from the Welsh pandemic record. So in the early days, we were pulling in data from all sorts of different sources, and a lot of it was data that was really messy, poorly characterized, partial, incomplete. And we've got a rule about, we don't write anything into the single record in Wales. And, we don't have to edit it after it's been added, right? It's right once, and it's important for clinical audit. So we had to have confidence in the data, but at the same time, we needed to use that data immediately for contact tracing, because you want to track the contacts within hours, right? Not within a week. So we came up broadly with a concept of kind of, like a dirty reservoir that then gets filtered into tanks. So the dirty data that comes in, we'd send it to contact tracing immediately because the clinical risk of getting it wrong was not major. And then we'd hold that, we'd filter it, we'd clarify it, we'd test it, we'd validate it, etc. And then we'd write it into the single record in terms of the test results and various other things. And some of that principle is coming along. We've come up with this term called data lakehouse. So data lake is the dirty water and data warehouse is the clean, characterized, consistent, semantically rich sort of stuff that we hold on to permanently. So some of that learning has come through into the national data resource. And then I'll just say something briefly about apps as well. We're working on an NHS Wales app at the moment, about to go into private beta and then full launch next year. It's modeled on and tightly modeled actually on the NHS app in England. So we took a code drop from them in November of last year, and then we've adapted it for Welsh purposes because it was in English only and it could not handle bilingualism. Okay. And I think the learning for me in this is one, that the NHS COVID-19 app, which is a different thing, that there was an England and Wales one, that was developed by a German company called Zulke, a subcontractor to NHS Digital and NHSX. That was multilingual from the start, and it was localized from the start. So it's one platform, but you could make it look Welsh, and you could make it tailored to Wales. They're different things. So you could put in an England postcode in London and ask for a Welsh language interface, and you'd get the English advice, the England advice, but all in Welsh, as it were. We don't commonly architect stuff in that way in the UK, and we've had to do a lot of work to turn the NHS app into that type of modular architecture, but that's a lesson we've got to hold on to. And then secondly, England used the COVID QR code pass as a way to drive adoption of the NHS app. They've just passed 30 million downloads of the NHS app. It uses the NHS login process. We've got something like 1.3 million people in Wales that have registered on NHS login. It's a very significant proportion of adults. But what they found is really intense use when people needed to show the QR COVID pass, and then usage has really tailed off because people have got the app installed, but there's not a lot that they can do with it. And again, I think there's some really interesting learning there that you've got to think carefully through how people are going to make use of the app that you've given them, and also that that people are not desperate to spend every day of every minute checking out their health record or reviewing their appointments or whatever else, right? They want it to be there when they need it, but when they don't need it, they'll largely kind of, ignore it. And we've got to kind of bear those things in mind. So I just run through those two. I'll pause rather than just, sort of monopolize the talk, and then maybe if we've got time, we'll come back to medicines or something.
Thanks,
Can I pick up there just actually, because I think Ivan makes a really great point about how we interface with our people and our communities going forward. And one thing we haven't mentioned yet, and it was springing to mind, because I think there is a real issue around digital inclusion, exclusion, depends on if you're positive or negative about these things, but actually also looking at how we address some of that and help with support of other organizations. And I've numerous dialogue with Digital Communities Wales, for example, and how they can help support, get our communities to interact far easier with digital technologies. But I think it's an important thing we shouldn't lose sight of, because we're talking about the expectation, or sorry, I was talking about earlier rather, the expectation of perhaps staff and change and how we've responded digitally, but it's also the expectation of our people, our patients, our communities, and making sure that we don't leave anyone behind in this as well, but also recognizing, as Ivan's just said, that there will be times when it's just not, they're not going to be that not interested, but not going to engage in the same way that perhaps they would when they need. It's got to be there when we need help, and actually making sure as a result that we've got the mechanisms and the support arrangements, not just within our own teams, but in our wider communities, to help these people and these communities to manage their care.
Yeah, the engagement that the Welsh NHS Confederation do in terms of their sort of patient engagement, and use a personal example of taking my father to a rugby game in Cardiff as things were opening up post-COVID to limited numbers. He couldn't have a ticket on his phone to go into the rugby because he didn't have a smartphone. But the good bit for him was he couldn't buy a pint either, because they were only doing order from your phone at the table. And, genuinely using that as a light-hearted example, it is a big issue around digital exclusion. But a question in which is related to a couple of the points that you both raised around where data is held, the National Data Repository, how different bits of information are held in different bits of the system, and different systems link up. And this question from a colleague at Cardiff and Vale Health Board about many departments having their own standalone digital record who don't communicate with each other, and just any sort of highlights really of work being done to ensure that when a patient goes to another department or another NHS organisation, just to help people understand what the plans are for making that better.
Ivan, should I start and then you come in on that, if that's okay? So and it's a great question, isn't it? Because I think we'd all recognise those challenges about disconnected data. We also, if you think of it again, by putting patients at the centre, them having to tell their story on more than one occasion. Some of the work that Ivan's already alluded to with the National Data Resource is going to underpin, so you don't have to tell your story multiple times in the future. But we do need better join up, and I'm passionate within CTM, and I was in my previous role, around how we evolve clinical services and non-clinical services in the future, very much more in the design and design and deployment, implementation of systems and ways of working, because that's the only way. If we get a better understanding, there's no point as digital teams trying to just roll out systems without that really strong network of a broad range of clinical folk. We've got a very active CCIO network, or Chief Clinical Information Officer network. I think the success, and Ivan may want to allude to this in a minute, with the Welsh Nursing Care Record, and how that's really been led by a multidisciplinary network of nurses, very much in the informatics space. And one area we now need to look at is our AHPs, our allied health professionals, and our pharmacists, how they help design to make sure that we have this seamless approach to the delivery of care through our systems going forward. I don't know, Ivan, if you wanted to add to that.
Yeah, I'm it's really important, isn't it, right, that we can move data from one place to the other, or that on the scale that Wales has, that we can consolidate data in one place. As there's this term that's been quite contentious in the past about once for Wales, but data has got to be once for Wales, right? You can't have multiple versions of the same data without knowing which one is the authentic or the accurate one. Yeah. And from a patient's perspective, people move across borders all the time, right? And they move between one region and another. They move out of Wales. They might move back into Wales. So data's got to be portable, and all healthcare systems are looking really carefully at this. So I'm encouraged by the emergence of standards that we didn't have 4 or 5 years ago. FHIR messaging standards or open air for record structures and various other things. But there's huge amounts of work to do. On the one hand, I'm like, well, why would anybody not want to just make the data that they've got available, to other systems? But it's never as simple as that, is there? Because the NHS has got lots of tribal and professional interests, but we also work with lots and lots of third-party suppliers, and they also have lots and lots of interest because data has value. You can use it for your analysis. You can use it, let's be honest, you can use it for a degree of vendor lock-in and a whole bunch of other things. So there are lots and lots of different reasons why it's not been as easy as you might imagine to be sharing information from one place to the next. And the only comfort, I guess, and it's like a comparative comfort, is Wales is comparatively good at this. Compared to not compared to integrated single healthcare systems, like Mayo or Kaiser or something, or Veterans Health in the US, but their partial population coverage for a whole nation system. Wales is really quite good in terms of the universal coverage of test requesting and test results, or of radiology images, and a bunch of other things. We've got a comparatively very comprehensive single care record. We've had a shared care record where you can read through into the primary care record from secondary care settings and vice versa for 4 or 5 years, and that's something that integrated care systems in England are only now struggling to do. There are other people in worse places than us, but that we shouldn't take too much comfort from that, because there's still a long way for us to go here in Wales.
Yeah. No, thanks very much. And you just mentioned in passing lots of the different systems. You started off a bit earlier in the conversation talking about how things were easier when you were on that sort of greenfield sites. And you mentioned, services in pharmacy, surgeons in secondary care, primary care, test results being circulated. And we've had a question in from one of the delegates today, very much related to that, is how are things around patient confidentiality and access managed, and how is the journey happening there? Because assumptions made in lots of patient engagement is if you enter the NHS, you assume that everybody you're dealing with has access to your data, which definitely isn't the case. So just interested to hear a view from both of you on patient confidentiality, patient data security, and views where things might get to.
Yeah, no, thank you. And colleagues, and hopefully many of you on the call will reflect on the GDPR regulations that came in a number of years ago. And actually, people have seen that as some colleagues have seen that in a constraining light. Actually, it's a really enabling piece of legislation in many ways, and that is where we drive those things around patient confidentiality. It's really designed to share data more, to open up things more, as long as we follow, as Ivan says, standards and rules on some of these things. And once we get past and understand that, I think we will be able to move forward. But I think we're still maturing at some of that. I think services, operational services, when you ask them to complete a data impact assessment, for example, it's seen as a barrier rather than an enabler to making these things far more seamless going forward.
Thanks very much. And as you were speaking, a very much related point came in from someone about, could you both explain how the NDR, Digital Health and Care Wales, and health boards work together on these issues? And the observation is that it seems a minefield joining up health records and systems, and there's something that's been worked on for several years. So just if you could help colleagues.
Can I go first on that one? So first, right, on confidentiality, patient data, the NHS and our partners, right, but the NHS takes it extremely seriously, really seriously. I've never worked in an environment that has got as much rigor and discipline and assurance and audit around the way that patient data is handled. It is very complex, and it's quite contested. And again, at the UK level, twice in the last 5 years, it's kind of blown up in the face of NHS England, first through care.data and then again last summer. I think there are 4 clear use cases, and the Welsh Government is doing some work around a data promise to define this, and the National Data Resource is calling it sort of data products. So one is the clinical use of data around an individual, identifiable data on the individual. as you say, people think that that is available across the whole of the NHS. It is to a greater and lesser degree, particularly in times of urgent unscheduled care, and that is really important. Right? You can't receive healthcare services unless clinicians can see your identifiable data. It's essential, right, to the provision of healthcare services. Then we've got the use of non-identifiable aggregated data, first for operation planning, on a week-by-week basis, and we've got loads of room to improve in terms of our use of management information of that sense. And then for population health analysis, sort of longer term, so 1 to 3 year type forecasting, modeling, planning, but also understanding disease patterns much more effectively, and how demand works across our system. And then as a fourth, there's research use. And there's loads of work done on this, the Gdpr review in England and the Digitrials initiative and a bunch of other things looking at that. So there's a lot of structure around it, if that is reassuring to people, which I hope it is. And sometime within, in the nearish future, there's a commitment from Welsh Government to establish a data promise that will bring more clarity to all of this. But I don't work for government anymore, right? So you're going to have to ask somebody in government for a position on that. I can see the question, right? It's a minefield. I don't think it's a minefield working between NDR, DHCW, health boards. Maybe some years ago it was a little bit, in that things could unexpectedly explode in your face. I don't think it's like that at all. Right? It is a complex system and a complex set of relationships. But I think they're in a really, really positive space. I think the working relationship between DHCW as a new organization and digital directors, especially through the peer group that Stuart chairs, I think is a really, really positive, genuinely collaborative partnership approach. And I think that, I know that the discussion amongst chief execs as well is much more digitally aware, digitally savvy. And that's partly that DHCW as an organization now exists at that table, the chairs group and the chief execs group, but it's also because of the experience of COVID and the way that organizations have worked together very effectively in that kind of space. So it's still complex, right? And there's still loads and loads of kinks that we need to iron out. But there's a clear direction of travel, and I don't feel that it's a minefield at all anymore. I think that's the wrong term there.
That's really positive. Any reflections from you, Stuart, on that one? I've got a couple more questions lined up as well.
No, I think it's clearly a long-term commitment, and I think that when people perhaps use those terms, it is thinking about when is it going to materialize, when's it going to deliver on some of these things. But I think it is absolutely the right way to go. We've got some of our best people across our digital teams and other services inputting into this program of work, which will, as Ivan say, unlock in the future. So I think it's a great direction of travel. We're all behind it. But I do understand when colleagues perhaps feel challenged by when is it going to deliver for us? And I think that's the challenge here, that we've got to just try and perhaps articulate a little bit better in our narrative.
No, thanks very much. And there's a bit of a theme developing in the questions around that sort of sharing of data across organizational boundaries. I've reflected with colleagues in some of the work that's been done in Public Health Wales and similarly in England related to vaccine uptake, where they're looking at postcode areas where vaccine uptake was low through the pandemic, which disappointingly but unsurprisingly mapped to areas of high deprivation. We saw that in a particularly low uptake amongst minority ethnic communities in parts of the country, particularly low uptake in areas of South Wales where there are high levels of deprivation. And that enabled some targeted encouragement and target marketing to encourage uptake in those areas. And I suppose we've talked a lot about data sharing across the NHS, but we're seeing it increasingly in Wales and other areas of the United Kingdom, a much closer working with social care. And there are multiple systems. DEWIS, don't ask me what the exact acronym is. I'm sure Ivan or Stuart will tell me, but systems in social care. And what we're seeing there is, opportunities to flag up through data areas where people might need support, or they might soon need healthcare support. So sort of thoughts on where do you stop really in that sphere of what information you've got about people and that identifying risk and targeting resources. So any sort of thoughts, observations there?
Can I sort of answer that and also try to move us a little bit into opportunities, I suppose, and then a bit of challenges. So if you look across the border at England, in June, I think they published a new digital plan for health and care, and they're making a really big bet on digital technology being the thing which will move the NHS to a sustainable future platform, new ways of working, new service models, and care it figures large in that. And you can see it in some of the stuff that the new Secretary of State in England has been pushing out at the moment, having just arrived in the role, about how can you use digital and technology and virtual wards and better information and segmentation of waiting lists and targeted intervention against, sort of cohorts that you can identify from all of that, use AI to change things, to enable the NHS to be much, much more efficient. Because we can't create more people. People are leaving the NHS in terms of employment at the moment. Our net headcount is going to go down. So any new way of working that requires more people to scale up is going to struggle. So let's bring digital and technology, and it'll sort everything out. And I call it the digital magic fairy dust strategy, because there's this narrative around the whole of the consumer world about how fantastic digital is. It's always about cutting edge AIs. It's about robotics. It's about whatever Elon Musk is up to most lately. And there's this whole there's like a tide of how fantastically transformative digital technology can be, and it's all about promise. And I think it's really difficult to identify the areas where digital can make that kind of transformative change overnight. Now, I'm a passionate advocate for digital, right? And we discussed the pandemic response. We could never, ever, ever have done it in the way that we did without digital. And the digital spend was tiny in comparison to the pandemic response. In Wales, we spent like 25 million over two and a bit years on the digital response. That is like value for money, if anything ever was. But there's still limits to what it is that you can do with digital, because it is not just going to suddenly change those things. So I think it's really, really important, right, that we extend our understanding of services through directories of services and DEWIS and a whole bunch of other things. It's really important that we bring digital technologies to bear on the whole social and community care and residential care space using systems like Welsh Community Care Information System. I think there are big opportunities in automation to drive efficiency through standardization of working by relieving people of repetitive, quite boring tasks, so that people who are quite highly trained professionals can operate at the top of their license, right? The maximum, and filling forms is not operating at the top of their license. So can we take some of that away? And these might be double-digit percentages in terms of improvement in efficiency, but they're not orders of magnitude, right? They're not going to enable the current workforce to deliver twice as much in terms of output in the NHS. Digital can't do that, right? There's a limit. So all those things that we've been discussing, I think there are real opportunities there. Probably some of them are unexpected ones. I have no idea, right, what technology is going to look like in 10, 15 years. And I'm not foolish enough to try to predict, never make predictions, especially not about the future.
Especially when being recorded.
Yeah. Well, yeah, play it back to me when I'm 65 and retired. I don't care what I've said. But I think, we therefore have to be really sort of practical and applied and not get carried away with ourselves. And some of the things that we need to do are going to be quite heavy lifting. Yeah. Some of them are going to be, quite hard work, but they're still worth doing, because investment in digital is a relatively quite small proportion of what it is that we spend in health. And I'm completely convinced, as I would be obviously, but that you get a really good return on investment from digital, albeit it's sometimes difficult to identify specifically and categorically what it is, because digital permeates every single thing that we do. So it's really hard to identify that specific thing. But I think it's worth investing in, even because, right, we value our professional staff. 2/3 of our spend in the NHS is people, and they deserve to be using the latest tools, right? They deserve to be using the latest tech. They want to use the latest tech. They use it at home. They get shiny kits, and then they come into a dusty desktop. Well, we've got to do something about that if we want to hold on to people working for us, give them a better working environment, better tools to do the job, more printers, and a whole bunch of other stuff. So, I think all those things are really important.
Thank you. We've had a fair few challenges.
Can I just come in there, Darren?
Yeah,
sorry, because actually, as Ivan was talking, I was reflecting on both of our previous roles, and we in a previous life, I was reporting and getting scrutiny from Ivan around what a digital hospital of the future looks like. I'm sure you remember that. But actually, it is really difficult to predict some of those things. What we come back to is making sure we put the foundation piece in place. The NDR is a core foundation for us. Putting those mechanisms in place. What digital has enabled us to do, and we've demonstrated, is we now bring in far more multidisciplinary team working together, and that's NHS, that's third sector, that's academia, that's industry. We are now able to speak, we are able to connect. We would usually, in pre-pandemic, we would be thinking about, oh, we're going to have to try and organize some kind of workshop, bring people in, and we'll probably get to it sometime next year. We've taken away that boundary, that distance boundary. So we have got a huge opportunity now to really, but also then use that flexibility within it, because the technology, as Ivan's just alluded to, will change over time, inevitably. So how do we just keep that linkage and keep those discussion flows active, so that we make sure that we keep responding to the needs of our population?
Yeah, no, thanks very much. And I'll give you both forewarning. I was sort of thinking about it, and you both pedal back and say what will be the biggest innovation or biggest change in 10 years. So I'm going to ask you to go to 2025, something a bit more predictable after the next couple of questions. There's a question in the sidebar. What's the best way to integrate digital into activity? I.e., there could be tech available to fill a gap or enable new ways of working, but service planners, designers don't know what's out there. And that's a bit that, not knowing what's over the horizon to sort out the problems you've got and how we do that. And especially when there's so many people competing to come in from the outside to solve some of these problems. So some views on that. And I was going to move on to a couple of questions then around digital roles in prevention.
So can I just sort of briefly go? So I'll kind of go first. So I think you should start with a service model, not start with the tech. There's an endless stream of new technologies being offered, and all of them are transformative, and all of them are interoperable, and all of them work with every system, and all you got to do is buy it, and then suddenly you'll have fantastic performance, and you have loads of time back, and you can do lots of other more important things. And we're inundated with stuff that comes from the market, and that can crowd out things, and it can generate enthusiasms, and sometimes maybe you strike lucky and it really is transformative, but often it isn't. And my general feeling is that if it's that transformative, it's going to come up and it's going to hit us in terms of practice anyway, because we all see what's going on across the sector. Senior leaders, whether they're planning or performance or finance or whatever, they go to networks and they go to peer groups and they go to conferences and they see what's coming up. And if there are things that genuinely are really changing, technology driven, and most of the things that are changing will be technology driven, they'll see them from there. On a Wales level, though, I think we need to focus on the service transformation that we're looking for first, and then how can we apply digital to make that work more effectively. When I was in Welsh Government, I was always saying that we will really have nailed digital transformation when it's the new service model that starts, and then that is presented to digital professionals as to how can you make this happen. So, I'd really want, people who are leading our national clinical networks and our national strategic transformation programs, the 6 goals program, planned care, primary care, etc., to be really digitally savvy, digitally aware, digitally enthusiastic, and various other things. But really, I want them, their professional core competence is their clinical practice. That's why, it's a clinical network or whatever, right? So I would want them to really work hard at trying to marshal the clinical community across Wales to consolidate onto new, better, more efficient, scaled up ways of working, because we've got so much unwarranted variation at the moment. And then to explain that to digital professionals, of which we've only got around 4,000 or so, right? Yeah. This is people whose core job is digital, and challenge the digital profession with how can you help us make this happen sooner, better, faster, and then make it stick, and give us the data routinely collected that will tell us how well it's going, that we can keep iterating as we go. And that's kind of turning things on its head. I don't think that we're there at the minute, because we keep being asked, have you got any digital magic dust for us? Where is it? And I think that's the wrong way to approach it. You've got to focus on the service delivery and the clinical practice. That is what the NHS is for, and that's got to come first.
No, thanks very much for that. I think I'm one of those people who ask for digital dust and who think Elon Musk is a 1970s aftershave and things like that. You mentioned earlier the role of nurses in and frontline health professionals in the development of things like the nursing care record. There's a question in the sidebar about allied health professionals, and any examples or any thoughts from both of you of how they're involved in the development of digital solutions.
Yeah, can I come in there first? And actually, I was going to link it back to Ivan's answers, which I absolutely agree with in terms of that system-driven approach. So, honest answer is not enough, and actually will be pockets. So some organisation, apologies, I don't know the landscape across every organisation. If I reflect on within CTM, we are now developing. We've got someone who's come forward who is going to be our digital lead for allied health professionals. She is joining in with our senior digital teams and meets with our senior digital teams on a regular basis. But actually what we are doing is trying to support them through education and development and using mechanisms like the Digital Intensive Learning Academy, the MSc programs within the University of South Wales and University of Trinity St David and through WIDI. That network, we're now starting to empower a new cohort of allied health professionals and others to come forward and really start to drive digital change or change enabled by digital rather. I know within Cardiff, for example, they've got a digital midwife, and our head of maternity services has come and spoken to me about, I want a digital midwife. And absolutely, we are seeing this multidisciplinary clinical led approach to digital, and we can't get enough of it. I suppose what we got to guard against, and it's in the opportunities and challenges piece that we may finish up on, is having the capacity to support them locally. And that's not saying we just need loads more people, although we do need more people and more digital professionals, as Ivan's alluded to. We still got quite a small cohort of digital people across Wales as their core day job is a digital role. But we need to support these people as they're bringing their expertise, their clinical expertise, and their understanding of digital opportunities. We've got to be able to support that with our digital teams going forward.
Thanks very much, Stuart. Ivan, is there anything else you wanted to? I just wanted to just to remind, we've got about 7 minutes left. So if you've got a question burning, please do pop it into the sidebar, and we will attempt to answer as many questions as possible where we understand them after the event today, and we'll post a link to the recording. Ivan?
Yeah, I used to be in government. I was amongst other things, I was the policy lead for health sciences and for allied health professionals. I wasn't a professional lead, obviously, but I would meet with the professional leads, national and regional, and it was partly, yes, absolutely right. We would want more people from an AHP background in the senior digital leadership, just as we want more people from a nursing background and more people from a clinical background, and because we want a diversity of backgrounds in the digital leadership. But at the same time, it's also about the AHP digital leadership, the AHP leadership itself being really organized and really clear about what it is that they want from digital, and kind of marshalling to influence within the system. We do inevitably. The NHS is a tribal system, and if you want to get your way and get heard in that kind of environment, you've got to get organized. And I think nursing especially has done that really, really effectively in the digital space over the last few years. The Welsh Nursing Care Record is an example of that. I worked very closely with Jean White and then with Sue Tranker around that. We supported Florence Nightingale Foundation scholars, digital nurse leaders, chief nursing informatics officers. That took a few years, but it's a kind of a clear trajectory, and it shows how a professional grouping can develop its ability to influence the digital agenda, I think. So in part, yes, absolutely right. The question is, why haven't we got more AHP digital leaders? It'd be great to have more AHP digital leaders, but that's not the whole of it. I think part of it is we want more digital leadership from the AHP leaders as well, and the two together are the solution to making this work.
Thank you very much. So 2025, 2020, what year is it again? 2022. What will they be, do you think, the biggest changes we see if we came back and had discussed this discussion in 3 years' time? What will be the biggest things which will have changed, and what will we still be working on?
Yeah, let me go first, right? So I'm going to come back to that. Right? It's really difficult to predict. It'll probably be unlikely things. I think that I think diagnostics is going to become more specific and more accurate, especially genetic type diagnostics, and more of it is going to be in the hands of patients. And I think that in 10, 15 years, you'll be doing an at-home using something like, the Oxford Nanopore USB stick or something, right? You'll be able to do circulating tumor DNA tests, and you'll be able to identify types of cancer genetically defined early. And then you'll be able to basically, not quite self-serve, I'm sure it'll still be broken through clinical health professionals, but at a really, compared to now, right, really early stage,
yeah,
you'll be able to get a targeted precision medicine sort of intervention. That is, I think, much easier to do in many ways than well-being and lifestyle and behavioral influences, because the psychology of why people behave in the way that they do is a really, really complex thing. But if you say to people, well, you've got a cancer type ABX1341, and this is the drug or the thing that sorts it out, that's what you need. That's what people want, right? So I think we'll see a lot more of that, and I think we'll probably see a lot more assistive deployment of assistive technologies, both for clinicians and for patients. So for clinicians, it will be, well, this is most likely so and so, based on a whole bunch of contextual factors, a lot of them drawn from data and other richer data than we've got at the minute. But for patients, I think this is where the really powerful thing will be, to help patients make informed choices about what the most appropriate intervention for them is.
Yeah.
If you read something like Daniel Kahneman's Fast, Thinking Slow, people are not engineered to be able to imagine themselves 20 years down the line. And if you say to somebody, right, so you're 45, you've got this illness, and here is the details on 2,000 people, your age, your background, similar to you, like this is you, and this third of them made this choice, and this third made this choice, and this third made this choice, and this is what happened to that third, they're all dead, right?
Yeah.
And this third are all hospitalized and really, really ill, and this third are living their life, right? They're having a fantastic life. So which one are you going to choose? We're nowhere near that at the minute, and data, I think, will enable that kind of population cohort, really punchy information.
Yeah.
But it's going to require clinicians to embrace that sort of aggregate. It's not quite the way that we do evidence at the minute. So I think there's some changes in that in that area, and flying cars as well. By the way,
flying cars. That's the one that'll stick with everyone. I was going to ask the question about the preventative, but you came sweetly into that. So quickly over to Stuart, and we've just got 2 minutes left. Sorry.
No, thank you. I not to repeat anything that Ivan said. I agree completely around the assistive technologies. There will clearly be far more demand on, should we say, virtual care in the future, and expectations of our patients and our clinical workforce to be able to do that, to enable us to manage services. I think the other thing that we will see, certainly in this period now until 2025, is the more significant rollout of e-prescribing and how the opportunities that will present for services. Our colleagues in Swansea Bay have very much led the way on that, and now there's a programme of work over the next couple of years aligned right across health boards, actually, to really change the way in which we are delivering some of our prescribing services. So I think that that will certainly come to the fore. But if we take that, we can't lose the sight of and I've said it a few times, sound a bit of a broken record in some ways, the foundational piece in terms of getting our data story right, getting the EPR elements right, that seamless flow of data, underpinned by some of these other programs and initiatives. I think that's where we'll be in 2025.
Thank you very much, and unfortunately we've run out of time. I'd just like to thank our presenters this afternoon, Ivan and Stuart. Very, very interesting, informative. A load of things that came up that I definitely hadn't considered. Thanks to the team in the Welsh NHS Confed for pulling together this event this afternoon, and thanks to all of you delegates for attending an excellent turnout. Just a reminder to everyone that the Welsh NHS Confederation Conference is taking place in the All Nation Centre on the 1st of November. An excellent programme there, top-class speakers. The first time we'll all get together face to face, not digitally as we have this afternoon. So an excellent opportunity for networking. Thanks all. Sorry our time is up, and look forward to seeing you all again soon. And we'll try to answer as many questions as we can afterwards in the follow-up, and the video will be available soon. Thanks all.